Hi, everyone. Welcome to PalliPulse, where palliative care is simplified. Today, we're with Dr. Mona Tareen, a palliative medicine expert whose own family story led her to a global mission. She's the founder of PalliPulse, an initiative dedicated to making complex medical concepts clear for families everywhere.
Thanks, Chris, for that awesome introduction. And today we're going to dive into a really big hot topic. Wait for it. Yeah, we're talking about medical cannabis. For those of you who actually know me, you know that I've done my master's in cannabis science and therapeutics. So everything that I discuss here is evidence-based. But one of the things I really wanted to clarify is that the word marijuana, which entered US usage back in the early 1900s, was borrowed from Mexican Spanish, marijuana. But that term became heavily politicized and stigmatized, especially during the era of prohibition and the so-called war on drugs. That's why in medicine today, we really no longer use the term marijuana. The correct, respectful, and scientific term is always cannabis.
Now, there's still a stigma around its use in palliative care and in medicine more broadly. A lot of that, I think, comes from misunderstanding. After all, cannabis is medicine. So let's take a quick 101 together. So, Dr. Tureen, how has medical cannabis evolved from ancient remedies into an evidence-based option in modern palliative care? And what challenges remain in, balancing culture, regulation, and science?
In answering your question, Chris, it's not really a simple answer, but here's what we actually know. Cannabis has gone from being a traditional remedy to FDA-approved medications. For example, dronabinol, also known as Marinol, is a synthetic THC which was first approved back in 1985 for chemotherapy-induced nausea and vomiting, and then in 1992 for AIDS-related appetite loss. Nabilone or Sesamet, another THC analog, also for chemotherapy-induced nausea and vomiting. Epidiolex, a purified CBD formulation, has been approved for rare pediatric epilepsy such as Dravet syndrome and Lennox-Gastaut syndrome. Outside the US, there's actually nabiximols, also known as Sativex, which is widely used for MS-related spasticity.
So, in palliative care, the evidence, it shows promise. Nabiximols can help manage cancer pain that opioids don't fully relieve. Dronabinol and nabilone, they work as well as standard antiemetics in some chemo-related nausea. Appetite stimulation, the data's a bit mixed there. Modest improvements, but not always weight gain. But patients often notice other benefits: sleep, anxiety, muscle spasticity. So the outcomes are promising, even if the research quality isn't always perfect, right?
The trouble is, everyone thinks cannabis is natural. In truth, it's a medication. But here's where things actually get tricky. Cannabis is metabolized in the liver by enzymes called CYP450, also known as CYP450. And think of CYP kind of like your cleanup crews. After medicines do their job, these crews break them down. But if cannabis blocks those crews, other medicines can pile up in the body, become too strong, and even dangerous.
Wow. Can you give us some examples?
Absolutely, Chris. So here we go. Examples are warfarin. Warfarin has interactions with CBD, therefore increasing risk of bleeding by causing an increase in what is known as INR. Tacrolimus levels jump when patients are taking CBD as high as 350%. Methadone and buprenorphine levels, they actually spike and rise and have interactions with CBD. So this is particularly important for patients who either are receiving hospice care or may be under the care of palliative medicine. Also, clozapine shows dangerous changes and levels. And so we see that there are a number of drug interactions, and you really need a clinician who has experience with CBD and THC. Not personally, of course, but has experience in recommending CBD and THC and has the clinical experience to anticipate the drug-drug interactions.
So, for palliative patients already on complex regimens, this really can't be ignored.
Correct, Chris. It's absolutely complex. So, walking into a dispensary looking at a cannabis formulation that matches your needs, you need to still be cautious. Clinicians recommend starting with CBD dominant formulations and adding THC only if needed, because part of the problem with THC is that you can get tolerant or used to it. And that kind of limits us to how much we can actually dose escalate. Think of it kind of something like opioids, right? And opioids are the medications we use for pain, like morphine and hydromorphone and codeine. I don't like to use the word narcotic because that's not the correct term, but patients can also similarly be cannabis naive or tolerant, and titration should always be slow. We go by weekly adjustments and not daily. The goal is ultimately to minimize dizziness, confusion, and falls, especially with an aging population where we know there will be about 1 in 4 adults by the year 2060, that we have to have experience so we cause less side effects. And we also need to focus on decisions that should include the patient and families and focus on what their care goals might be.
Of course, there are red flags. Under age 25, pregnancy or breastfeeding, a personal or family history of psychosis, unstable cardiac conditions, or being on certain strong medications that interact with cannabis. And that's your pharmacology moment. So, should we or shouldn't we use cannabis in palliative care?
We also have to realize, right, Chris, it's definitely not a cure-all. But when carefully integrated, it can be a valuable tool. FDA-approved cannabinoids have opened doors, but we still need stronger research and clearer regulations. So, what's the bottom line? You have to always weigh the risks and the benefits and keep the patient at the center of care.
Thank you, Dr. Tureen. To hear more on palliative care, follow us at PalliPulse, where we make palliative care simplified.